We are going to start with our first afternoon session, a very important one, the power of a multidisciplinary team. So joining me on stage is Nandita Vas, Dr. David Freedman, Madison, Dr. Arun, Reginald, and do we have some comments? Dr. Tania Bruno, welcome.
Hi, my name is Nandita. Welcome to the Power of the Multidisciplinary Team panel. We have a very exciting panel over here. I do want to explain a little bit that a multidisciplinary team isn't just composed of individuals. It's composed of a community that tailors to the holistic needs of patients, whether that's the emotional, the physical, or the social well-being of a patient. So in this session, we will have this wonderful panel explain through some of the ways to manage symptoms, manage pain, provide some resources, and the last 15 minutes, we will open the floor up to all of you to ask some of your questions, your reflections, your comments that you would like to ask to these panelists. Okay, so let's get started. If you could all explain or present your name, your role, and the type of patients that you usually deal with.
First of all, I'd like to say I'm absolutely delighted and feel very, very privileged to be part of this day. So thank you very much for having me. My name is Tania Bruno, and I am a specialist in physical medicine and rehabilitation. So that's a medical specialty, an independent specialty. And it also goes by the term physiatry. So sometimes people have never heard of that, and maybe persons here today may or may not need the services of a physiatrist. But my area of expertise is subspecialized into helping persons living with very serious neurological conditions have their best lives. So basically, it's a specialty devoted to symptom management and helping persons optimize their independence in day-to-day functioning while living with impairments. So impairments could be things like pain or mobility limitations or spasticity or bowel and bladder problems, and the list goes on. And also helping them deal and navigate through what is called activity limitation, which is the term that is preferred over disability, I think. And also restrictions in social participation. So when a person has multiple symptoms, that can affect everything from their family life to their personal and mental and physical well-being, to their roles in society, including accessing things outside the home and maintaining employment. So I don't do this all alone. I also work with a team, sometimes the colleagues here that are on this panel, but also persons from other health disciplines, such as physical therapy, occupational therapy, social work, speech language pathology, psychotherapists, and the list goes on and on. And I also have recourse to other medical specialists that collaborate with me, like bladder surgeons, urologists, and the list will go on. I won't take too much more time to explain that. I am appointed at the University Health Network Toronto Rehabilitation Institute and cross-appointed at the hospital, at St. Michael's Hospital. So that's where I do my full-time practice. That's affiliated with U of T.
So I'm David Freedman. I am a multiple sclerosis neuropsychiatry fellow. So my medical training is in psychiatry. And then I'm currently doing additional specialized training specifically in multiple sclerosis care, focusing on depression, anxiety, and cognitive dysfunction. But of course, as a lot of clinics exist, I also see many individuals with these rare neuroinflammatory diseases, and primarily with a focus on addressing the hidden burden of depression, anxiety, and cognition. So similar to many of the people here, I work with a variety of people focusing on addressing these conditions, both from a standpoint of lifestyle interventions, thinking about things like blood work and other potential contributors, how their other symptoms of their conditions may be contributing to things like depression and anxiety and cognitive dysfunction, and also thinking about the role of psychotherapy and medications. So it's a real privilege to be here. I'm really fortunate to work with such an amazing team through the Barlow MS Center and at Sunnybrook Health Sciences Center, and to just learn from incredible mentors along the way.
Hello, I'm Dr. Arun Reginald. I'm a pediatric neuro-ophthalmologist. I practice most of my pediatric ophthalmology and neuro-ophthalmology as a great privilege under the auspices of the Hospital for Sick Children, where really the multidisciplinary team is humbling in respect to the fact that umbrella of having so many people who are all together dedicated towards trying to do what's best in a personalized way for the children and their families is something that is a wonderful experience. I want to say thank you very much for bringing me today to speak to you. We just had our breakout session with the pediatric group, and it was wonderful to hear the stories from your perspective, as you are part of the team as well, as you know, as parents and carers and so forth, and having that insight into how these diseases, which are rare and sometimes far between, are how they affect you personally is incredibly important for us to hear, as well as for us to be up here telling things and hopefully imparting information to you, because it's with that collective experience that we can really, you know, learn what matters most for you and how to move forward with that. Thank you.
Thank you. My name is Madison. I'm the social worker at the Barlow MS Center. So my role on a multidisciplinary team is really around system and resource navigation and working with folks, obviously primarily with MS, but also these rare neuroinflammatory disorders, to get connected with the supports that they need and really identifying what matters to them, what their goals are, and how we can leverage supports in their community or at our center. I work really closely with our professional team as well too, so our physiotherapists, occupational therapists, pharmacists, psychiatry, and really trying to identify what those areas of support might be, especially around those key times, I'd say, around new diagnosis or changes in function, changes in how people are coping in their day-to-day. So I'm also just wanted to say I'm so grateful for social work to be included on this panel today. It's really such a pleasure.
Okay, thank you so much for sharing. I know chronic and neuroinflammatory conditions have a lot of overlapping symptoms, whether that's pain, fatigue, mental health challenges, mobility issues. So what are some common symptoms that patients usually present with? And how do you work collectively as a team to approach this?
So when I have someone in front of me and I'm starting to take a medical history, besides getting to know what their social circumstances are, what their background is, who they're living with, what are the kinds of things they like to do or need to do, then I take a body systems approach and we pretty much go head to toe and we figure out, so are you sleeping well? Tell me about your sleep. What is your energy like during the day? Do you suffer from pain? If so, where? And it'll go body system by body system. And when we're dealing with any underlying condition that involves the brain or the spinal cord, almost every system can be affected. So the approach that I take in my clinic, and this would be true of many of my colleagues, of course, would be a holistic approach. Because where you're suffering with one symptom, that might have ripple effects for a second symptom. And if you're feeling under the weather from something completely unrelated, that might unmask other burdens of neurological impairment that you're not able to compensate for well enough. So it's very broad. Everybody is an individual. Everybody will have a different constellation of symptoms, but that can change over time. So revisiting the body systems and revisiting what the burden is with each encounter is a really important part of what I try to do in my own clinic with persons either living with multiple sclerosis or other neuroinflammatory conditions like NMOSD, MOGAD, etc.
So in my clinical setting, I'm frequently seeing people for conditions like depression, anxiety, cognitive dysfunction. And I think one of the things that I think taking a step back, I'm often thinking about key principles in care. And I think one of the things that I find is we know that conditions like MS and these rare neuroinflammatory conditions, there's an elevated prevalence of things like depression, anxiety, cognitive concerns. And when people are hearing that sort of statistic, it can feel really scary. It can feel like I'm resigned to that experience of I'm going to inevitably develop a depression. And that's not the case. We know that even though there's an elevated prevalence, there's still an incredible importance of hope and agency and compassion for yourself and what you're going through. And so I'm often thinking, as I'm thinking about these individual symptoms, and I think taking a very similar approach as Dr. Bruno, and I'm trying to think about something different because I think I take a very similar approach to Dr. Bruno, but I think I'm often thinking about how can we foster hope and agency in this clinical encounter. So maybe it's thinking about what is this person's supports that they already have? What are the strengths that they've already taken? I mean, just by inevitably, like when people come to see a psychiatrist, they've already tended to do a lot of advocacy through the system. They've tended to already come for help. They tend to be thinking to the future. And I think that's a strength of a lot of the people I'm seeing. And so I'm often thinking about those elements. And then also thinking about the fact that even though there is an increased prevalence of many of these conditions like depression in this population, the importance of identifying it as depression, as a persistent set of feelings like sadness, low mood, changes in appetite and sleep, changes in energy that all come together and have this very persistent form, is because it's addressable. Like once we're able to identify something as a depression, it identifies something that we can then work together in order to actually get better. Whether that involves exercise, whether that involves therapy, whether it involves medications, that's all going to vary depending on the individual person. But I think that's really where it starts, with identifying these conditions, identifying that life with these conditions can be hopeful and optimistic, which I think is so amazing about then also think of making sure we identify depression so that we can address it.
That's powerful stuff, David. So ophthalmologists work in the dark. So I live invariably in the sort of the basement of a tower of excellence where we don't need to have any windows. And my role is really, I'm either in some situations where the first person that sees the family, sees the patient. So they've come in with a loss of vision, which will now open the door to the question as to whether something else is going on, something else that's involving the brain, whether or not that's a part of a condition where the multidisciplinary team are going to be involved, and we're going to be giving inputs to our colleagues sitting over there in the table over there with the neurologists, and then recruiting all our other team. And then sometimes they're the people who have seen the child first, and they're asking, hey, are the eyes involved in this? Can you give us some more information about this? Should we broaden our net? Should we be looking for something else as well? So we have that sort of role. And then like many of the physicians here, I can actually see, some patients that, you've diagnosed way long ago, and now you've see them going through, we were talking about transition. And so then you're monitoring these patients, and you're there hopefully for them when they think that in some of these conditions which are unpredictable and have remissions, that you might be the person that they're going to come and ask, is this something we should be worried about? Does this mean my disease is back? Does this mean that we need to think about changing things? And that's an important role as well. And then finally, you have to say goodbye to your children. So, at the end, you have to help them transition to the adult piece and help them build their network, and also be able to, try and help them to advocate for themselves, tell them the signs and things that they're worried about, that they should be worried about, the things that they should, keep their eyes out, because they're going to become their own quarterback for their own health from then on.
These are tough acts to follow. Typically, I get involved with folks. I have a specific referral for a specific concern from our physicians at Barlow or at other sites that we're connected with. So it can be extremely broad. In terms of symptoms or challenges that come up very commonly and sort of how those symptoms impact folks in their day-to-day and their coping, I think one thread I pull a lot is around fatigue. I know that's come up so much in the discussion today around fatigue, and mood as well too is often one where I'm becoming involved and getting folks connected with more supports around that, often coming from David's caseload. And so what are some other supports other than medication that we can leverage and connect folks with to help with their coping? Obviously around fatigue, that looks very different for everyone. And can that be involving my occupational therapy colleagues for some fatigue management and energy conservation strategies? Can that look like advocating and supporting folks for accommodations at work or school? And what does that really scary process look like around disclosure with your workplace or what have you? Does that look like making a transition in your life and accessing income supports because you can't work anymore? Obviously, that being an extreme case. But just it looks very different. My interventions look very different for different folks, obviously. But just talking about common, I think, fatigue and mood are big ones that come up for me.
Okay, thank you. Okay, I think it's the time to open the floor to the audience here. If you have any questions, comments, reflections that you would like to share, please raise your hand and I think someone will pass you the mic.
I have a question for David. When you're looking at
so we can hear you.
Sorry about that. So my question is for David. When you're looking at the patient and what recommendations you have, do you take into consideration, like if it's a child, the parents or the family members are wrong also within your diagnosis?
So it's a great question. I'm often thinking about that sort of social network. Certainly my focus when I'm seeing someone is on the individual in front of me and focusing on that person's care. But I think back to right when I start an assessment with someone, like after we've gotten through that sort of initial preamble, what's going on, what's going to take place here, the first things I'm often asking about is what's the living situation? Who's in the home? Is the person in a relationship? Do they have children? Are they driving? Are they working? I think these are all really important facets to understand the network. And then, so that's often right at the beginning. And then later on, after we've spoken about what are they dealing with and some of the contextual stressors, thinking about their past mental health history, medical history, medications, allergies, family history, we often spend a big chunk of time talking about the social context, like what Dr. Bruno was also talking about, thinking about where was this person born? What was their experiences growing up? Because I think although these conditions come after birth, the ways that people navigate illness and the ways people cope with stress often relate to some of those early life experiences and their experiences with illness in the family as well. And so I think, and then frequently, I actually am also thinking about the fact that there's many people that I see that come with a family member to the appointments, and it is I tell people that it's invaluable. Like I don't have any raw data or like amazing research to back this up, but like I often am saying to people, the fact that your family's here is probably a protective sign. The fact that you're more likely to, like, we know that families are, when families are involved, people do better. And I think that, of course, saying that, there's always exceptions. There's also situations that go on in many people's families where that is not a possibility and it makes more sense to see the person as an individual. But I think understanding the family dynamics is so important to understanding the experience of mental health issues.
Thank you.
Thank you all. I can confidently speak for patients in the room to say we have immense gratitude for multidisciplinary team members. On my question, so thank you. My question is about Dr. Google. So in particular about trusting medical professionals. And I'll share a short anecdote, which is that early on in my diagnosis journey, I saw an optometrist who I respect and liked her, and she thought I had dry eyes. So as my vision deteriorated, I would speak with my lovely wife, who would say, "You should get it checked out more. Like this is getting worse." And I would say, "No, let's trust the optometrist. She said it was dry eyes." It turned out years later, NMOSD. So I'm wondering if I just want to ask an open question about Dr. Google and about trusting medical professionals, and any advice you have for patients in terms of striking that balance with different perspectives about a particular case or patient. Thank you.
Should we take our stab down the row? Okay, so I think we live in an era of a ton of information overload, and we have to be incredibly savvy to navigate it all. And we can run into some pitfalls, but we can also help elevate ourselves and access resources for free. And so trying to find that balance is a really important thing to hit. I think if there are persons in your care community that you do trust, you can always ask them, what are the resources available to me online that I can go to get more information? Having used just like a Google search and getting the AI little blurb that comes right up, I can tell you that that's not always accurate from a medical perspective. Sometimes the information there is quite good. If you then do a little bit of more research and validate it, it's not always 100% accurate. So it's much better not to just rely on what the AI bot is telling you, but to go to trusted organizations and trusted websites. Some of those could be through the Samara Foundation, for example, and there are many other usually nonprofit organizations, university organizations, or other healthcare organizations that are really, really good resources. And that can be a wonderful way to supplement the information you're getting from your doctor's encounter, because when you're in front of your doctor, it may be a short or maybe a long visit, but there's also a lot that's going on that you may not remember right in the moment. So having a really good portfolio of places that you can go and check, I think is a good thing, but it has to be the right sites.
I don't have much to add. I think that was very eloquent.
No, I do agree. I do, with that. I think it's exactly as you say, Tania. It's about how to curate all this knowledge that we have access to. And the algorithms of Google is that it's the path that is the most trod. So it is not necessarily the correct path. It's not necessarily the path that the experts would agree with. It's the one that was the most catchy. So if you Google an actress, you're going to get 6 pages of scandal and then 1 nomination for an Emmy. It's not going to give you the information you want, because it's just what everyone finds interesting. And sometimes for us as physicians, we sometimes find that people have found the scariest thing on the and associated it with their condition, and then you have to unravel that piece before you can get to the condition. So time spent taking away those things that have been put on the table unnecessarily. I'm sorry for your experience with the delay in your piece. That is always sad when you have your concerns, and I think that from that perspective, as Tania said, you have your trusted places to go, and I think that they, as a place to springboard where to go to next, is the piece. But when you're really lost, then it's super difficult. And I hope that all of the internet and the knowledge piece, it is a good thing, and I hope that something like open AI and Atlas and cloud and all these things will allow it to become better. And I think it's really up to us, as what we put into it is what tells it to what it should spit out. So we're also responsible to build databases which are curated, which are trusted, and so they can become the point at which the people take off from, rather than just going to Google.
Just very quickly, kind of related in the topic of, I think, the proliferation of information that's available. A question and a concern that comes up, I've had many conversations with a few patients about this, is around like MyChart and accessing MyChart and looking at our notes and our imaging on MyChart. And should I look before my neurology appointment? Should I not? And I think there's certainly benefits of having all of that information at your fingertips, but understanding that that can be really scary as well too, that you're looking at this and maybe you've got 6 weeks or 4 weeks before you have that follow-up with your neurologist. And I think recognizing that it's important to look at that information for some people, they can't, some people do, but remembering that there's important contextual conversations that need to happen around a lot of those results, and as well too. I think ultimately a great thing that we're having more access to our medical records, but I think listening to yourself and maybe some of those anxieties or discomforts that are coming up as well too.
Any final questions for the panelists? One right here.
Hi. So I just have a question around how would you guys give advice to patients who might be going to multidisciplinary care teams and allied health professionals, because not everyone is aware of NMO, SD, and how would you advise patients to communicate their needs so they get the full breadth of the help that they need from these professionals that might not know as much about NMO?
So I work in a very, very, very wonderful little niche in that I am connected with a whole bunch of providers that are very well informed, but I recognize that that's not always the case. And so I think if you have one trusted professional that does know, let's say it's your neurologist, having that person guide you with a referral, guide you with connecting you to another provider that might have a sensitivity to that. Sometimes that curated word of mouth is probably the best thing. The other thing is sometimes I've had people come to me in other contexts where they've already printed out, this is for some even rarer conditions, they've already printed out for me an information sheet. I'm like, oh, this is very cool. Thank you very much for providing me. Or they've come prepared with their medical history and some of their hospitalizations or some of the other really high points in their medical journey. And that can be really helpful. That could be helpful with a primary care physician. It can be helpful with other members of health disciplines teams like a PT, OT, or if you're even transferring from one geographic location to another and having to rebuild your network. So ideally, you would have a referral to someone in that geographic area, but you might want to gather all your data and have a few introductory letters and help you on your way in that regard.
I echo a lot of that because I think there is so much that comes from that question. Behind the scenes, I think that's where those development of those partnerships between multidisciplinary teams and certain providers, so that they're seeing more of people so that even though someone has a rare neuroinflammatory condition, it's not the first time that person who they're being referred to is seen, but at the same time, that doesn't exist in all settings, and we can both work toward while also working in the reality of the day-to-day. I echo a lot of what Dr. Bruno was saying. I also was thinking on that piece, I also find it very helpful when there's a printed history of it. And I think thinking about that timeline of your symptoms before you come into the appointment, so that it just gives you that confidence or a little bit more certainty about when did things happen. It doesn't have to be perfect. All of us, things sometimes start gradually. We're trying to make sense of when approximately, but I think having that sort of timeline I would imagine can help with then if someone that you're speaking with is not as familiar with the condition, just understanding your experience a little bit better. And also just thinking about it from like a medical standpoint where we're often thinking about timelines. So it sort of helps to sort of take your experience and it then sort of puts it in language that I think is probably easier to be understood for a lot of doctors. I'm trying to think otherwise. A lot of what Dr. Bruno's already covered is what I would agree with. So I think that wraps what I'll say.
Was your question about how we do it, or how should we do it, or how should you advocate for your caregiver to do?
Yeah, kind of like how like patients, caregivers can advocate so that we relay the right information to receive proper care.
So and I've got my social workers sitting next to me, but it's all about connection, isn't it? It's about basically making sure that, you know, when you come and see us, that's not the dead end, and we're not a silo on our own, and we're seeing your eyes every 6 months and not telling anyone about it or whatever. So I think in terms of for your part, you know, having the contacts for all of your team so that we can start getting connected, and from our part making sure that we do our bit to make sure that if you register and you haven't got a family doctor and you haven't got this and you haven't got that, but we don't leave it at that, and we make sure that, you know, we can give you copies of your letter, we can ensure that your family doctor has copies of the letter, we can wait for you to give us correspondence for the neurologist and so forth and whatever. And then, you know, with your permission, that we're all communicating as well. And that connection is how you build your network. Does that answer?
I think just like really briefly, and I can only speak obviously from the context of our clinic, but talking about like accessing some of those different allied health supports, I'd say when in doubt, like come and ask us, come and leverage your team, and in terms of where to go, right? And sort of which path to go down, what might be helpful. We're absolutely here. It's a huge part of my role. I recognize I can sometimes only be involved for a short period, but let's get you sort of on the way to where you need to be or who you need to be connected with. There's no silly questions, like please come in and ask us.
Please join me in giving this lovely panel a round of applause.